Good afternoon, everybody. Oh, one more. I'm Ryan Ilgenfritz from Nemours, Department of Orthopedics. I'm going to be talking to you about sort of an orthopedic approach. This is something you've heard several times today. This is all changing. The way that we think about children with SMA is completely different today than it was a few years ago, and a few years from now, I envision it being even better. So that's sort of the direction where everything is going, fortunately. So this is the outline of my talk. I'm going to go over a couple of concepts initially related to the history of orthopedic treatment in SMA, where we are now and where we will likely be in the future. And then specifically go into concepts involving spinal deformity, which is sort of the traditional orthopedic treatment that has been applied for the longest period of time, at least to children with SMA. And then talk about lower extremity contracture management. And then I have a few slides about hip management, which is something that has been ignored for a long time for most kids with SMA. In this slide, the picture on the right kind of shows what we're trying to avoid from happening. So historically, quality of life and expected survival was sort of what we talked about and how we managed the care of children with SMA. And we tried to focus mainly on spinal deformity to try to optimize thoracic volume and lung development, which are concepts that we just heard from my pulmonology colleague as well. And then other treatments were limited to therapy and bracing to prevent contractures, and hip instability and dislocation has not been historically treated. And the reason behind that was the children that had hip instability and dislocations had a lower chance of survival into later childhood, so it was deemed inappropriate to operate and do big surgeries like that on kids if they were not going to have pain from a hip dislocation. And where we are currently, the medical treatments and the therapies are effective and promising and only getting better. And with that comes the possibility of a better long-term prognosis and further improvements over the course of time. And many children are becoming optimized to participate in weight-bearing therapy, which was not always the case before. And new technology is allowing us to intervene early with children. So this is a picture, as opposed to the last slide, of a sort of the newest spinal implant for younger children with severe spine deformities that's referred to as the magic rod. And then in the future, if the outcomes continue to support being more aggressive and optimizing children when they're younger, should we intervene before problems develop? And should we now routinely apply concepts that we use for other neurologic or neuromuscular conditions and idiopathic conditions in children with SMA to try to prevent bad things from happening, or things that could limit their function and maximize their rehabilitation in the future? So then we'll go into spinal deformity. So this is that same picture from before. So the history with bad spine deformities were that a severe deformity in a young patient was considered a poor prognostic sign and sometimes wasn't treated. Severe deformities, like you see in the picture to the right there, more than likely was going to be in a child that didn't survive. This child actually is 7 years old in this picture, so this is a relatively modern treated child with just a neglected spinal deformity. And the surgery was mainly used in later onset children to stop deformity progression and to stabilize their pulmonary function. And the gold standard was a definitive fusion, which means getting the spine to grow together so that the deformity cannot get worse over the course of time. But early growing spine technologies, which I'll go over in a bit here, were being applied at higher volume centers, but not routinely utilized across all orthopedic providers. And then the present is that patients are improving with new medical treatments, and children with bad spine deformities when they're younger have the opportunity to survive and improve and function over the course of time. Bracing and casting, you see several braces in the room. They are a bit controversial if you look at the big picture and if you talk to enough people that take care of children with spinal deformities and SMA. Some people don't believe bracing is helpful. I disagree. And modern growing spine technologies are limiting the need for anesthesia. So the Magic Rod, which is what you see on the right side there, is a device that can be lengthened in the clinic. It takes about 30 seconds per rod to grow the thoracic volume over the course of time while children are still growing and developing, as opposed to taking them to the operating room and putting them under anesthesia each time you have to lengthen the rods. And then, like I said earlier, the thoughts are focusing more on obtaining normal thoracic volume and lung development as opposed to just improving the volume and the lung development over the course of time. And then what does the future hold? So will the medical treatments decrease spinal deformity progression and even keep some kids from having it? So this is a patient that I saw recently that has no spinal deformity at all. This is something that we've seen in Duchenne muscular dystrophy, where children had severe, very bad, life-threatening deformities at younger ages, and then with modern treatments, not all of those children develop spinal deformities over the course of time. And then if we're having improvements with medical treatment, will bracing and casting be more effective and limit the need to operate on kids when they're younger? And should we have a more aggressive threshold for surgical intervention in children who are developing a worse deformity earlier in childhood? So this is an example of bracing treatment. You've seen the real-life examples around here. It may be effective in delaying progression in early spinal deformity, but it is controversial. Like I mentioned, there are some people that do not use bracing at all. But is there a future where bracing may be all that we need for a lot of these children? And then this is a concept that's applied to idiopathic, so not caused by a neurologic or muscle problem, and that's casting. So this is a child with an idiopathic spinal deformity who was 2 years of age at the time of this x-ray and has almost a 100-degree curve, and over the course of time, that can be improved with casting. And the casting image is on the right there, where you can see the deformity is only about a third of what it was without the cast. And then these are terms that Dr. Finkel mentioned in his talk earlier this morning. We have better treatment options for children that are younger with surgical level spinal deformities. So traditionally, growing rods were telescoped rods that required repeated surgeries to lengthen the rod over the course of time to try to grow the thoracic volume. The second iteration sort of that technique was what's referred to as vector. It'll make sense a little bit better when you see the picture, but it stands for vertical expanding prosthetic titanium ribs. And the technology was made to connect to the ribs in the pelvis and avoid the spine, but it required repeated surgeries as well. And then the Magic Rod, aptly named, is the newest of the iterations of growing rod techniques, where it does not require repeated surgery until you run out of growth. The rod can only grow a certain amount depending on the size of the child, but you can replace the rods and continue to grow the spine for even longer. So we don't yet know how long that process can go on, but without repeated surgeries and scarring, the outlook is good that we can grow the thoracic volume for many more years than we could with the other techniques. And then there's definitive fusion, which I'll include a slide on as well. So this is a traditional growing rod. It may be a bit hard to see. I don't know if you can see. Does the mouse show up on there? It doesn't? Okay. So the rods are grown at this junction point but it requires actually putting a distractor inside there and expanding it within that section of the rod, which you have to make an incision and expose the rod in order to do that. But were the sort of gold standard for many years. And this is an example of a vector construct which connects to the pelvis and the ribs. It was originally invented to expand thoracic volume, but also can be used to control spinal deformity. And this is an example of what magic rods can do. So all of my SMA patients under the age of 10, for the most part, have magic rod technology implanted simply because they don't have to have anesthesia over the course of time. And there is currently no competitor to the magic rod as it is protected currently, but that should change hopefully in a few years. And here's a side view of the magic rod showing how it improves the kyphosis and the thoracic volume as well. And it can also be used in other ways. So this is a patient of mine that has the thoracic deformity that is pretty common, sort of the bell-shaped deformity, and she was only 3 years of age at the time, having a lot of difficulty with pulmonary function. And so this is sort of a combination between what used to be done for a vector and a magic rod, where I'm actually pushing the ribs out to try to expand the thoracic volume over the course of time. And you can see the example of the side view of that same patient. And then definitive fusion is usually in children over the age of 10 or in rigid deformities where other technologies are not possible. You do have to have some flexibility in order to connect a straight device between the top part and the lower part of the spine. And this is that same example that I showed earlier, but this is, he required a definitive fusion because of the severity of the deformity, but also a good correction and a pretty substantial increase in his thoracic volume. So moving on to contracture management, this is a lot in a few slides here, but typically children with SMA will develop sitting position contractures if they are not able to stand and ambulate. So at the hip, that usually involves flexion contractures and adduction contractures, meaning that the knees become closer together. That combination of contracture is likely what causes children to have hip instability and dislocations over the course of time, and combined with what we call a coxa-valga deformity, where the angle between the ball of the femur and the shaft of the femur becomes greater, to where the ball of the hip joint points outside of the socket. So that combination of problems is what leads to dislocations over the course of time. And they typically will develop flexion contractures of the knee, and then what we call equinus and cavo-varus deformities at the foot and ankle without good therapy and good bracing to try to prevent that from happening. So this is sort of the present where we are with contractures in children with SMA. More of them are able to participate in weight-bearing activities, so our focus is shifting towards improving contractures early and absolutely trying to prevent them if we can at all, so that they can be active in weight-bearing therapies, because it's good for bone health, and children have less chance of developing dislocations of their hips and spinal deformities if they are more active in weight-bearing therapies. And then bracing and serial casting can be helpful in some children earlier in the process before the contractures become more severe. And in the future, we may be applying techniques that are used for other neuromuscular conditions for contractures. That's not recommended currently for children with SMA, but with improvements in medical treatment, that may be in the future. And then surgically treated, or surgical treatments for contractures typically was underutilized, in my opinion, in the past. The sort of orthopedic dogma was that if the child isn't going to be able to independently walk, they need to be in a sitting position anyway. So that's something we obviously are getting away from because we know the importance of weight-bearing therapy in these children. So muscle and tendon lengthenings can be very effective to optimize children so that they can continue to participate in weight-bearing activities. And we have begun to do that more aggressively at our hospital. We're trying to set children up to the point where they won't have the same limitations in their mobility as they get older with better medical treatments. And then the last statement there is, should SMA children be treated the same way that all of the other children that we treat? And I think that answer is yes, and we will continue to prove that over the course of time. And then I wanted to include a little bit about hip instability. So this is an x-ray from a child that I did a spine surgery for severe deformity, and her hips have been dislocated for years before her spine deformity was addressed. And this is a good example that I was talking about earlier of hips that have been out for a long time because there's pretty severe deformity of the femoral head. And you get to the point where you can't put the hips back in the socket. So that's something that we'd like to get to the point where we're not dealing with that anymore. But historically, it was sort of accepted that the majority of children will develop dislocations, and it's related to a combination of low tone, which we've been talking about a lot today, but also muscle imbalance because different muscles are affected differently. And the muscles that tend to want to move the hip out or the hip out of the socket are stronger relative to the hips that would keep them in the socket. So that's what causes it to happen over the course of time. But the belief is that early on in the process with low tone problems like SMA, the anatomy is relatively normal, as opposed to other neuromuscular conditions where the anatomy is typically very abnormal. So that will come up in the next couple of slides. So if we can keep them from developing subluxation early on, then we may not need to do more aggressive surgeries on them when they're older. And then there's that statement again that most patients didn't survive long enough in the history of SMA to become painful, and that's why oftentimes the hips were never even x-rayed when children were younger. Is that the same slide? Oh, those are both the same. So I mentioned this earlier. These are the things that develop that cause the hips to come out of the socket and dislocate. So hip flexion contracture is what we believe is sort of the first sign. Addressing that early and addressing hip adduction contractures early. So when children like to keep their knees together as opposed to sitting in a frog position, that can be very helpful to try to prevent the hips from subluxating over the course of time. And if you can address that early on, you may be able to avoid them developing the coccyvalgus deformity, which is a setup for them becoming unstable over time. And this is a good example of a child that when her legs are straight down, her hips are about halfway out of the socket, so pretty severe subluxation. But when you relax the hip flexion and adduction contractures, the hip goes right back into the socket. So that's a child that intervening early and addressing the contractures could prevent them from having a dislocation. And I think I already kind of went over most of this. The medical treatments could be changing this, and intervening early is probably the right way to go. So we do know this is another example of hips that are very far out of the socket and very deformed, so likely has been like that for several years. What we do know is as kids are doing better and progressing in therapy, they are more limited in their therapy because of hip dislocations. another sort of orthopedic dogma was that we shouldn't do anything about their hips if they're not going to become painful, because some children have idiopathic hip dysplasia and have dislocated hips, and they're not identified until they're older, but they live normal lives. The way that I think of that is that those are children where everything else is normal. So having one thing different and having hips that are dislocated may not be enough to limit them and keep them from weight bearing and being active and living normal lives. But when you have many different things that are not normal, having hips that are dislocated may pretty dramatically decrease the child's function and ability to rehabilitate and be active in weight bearing therapies. So what I envision as a future is addressing these problems early on and more aggressively in kids with SMA, so that you can set them up for the potential to rehab by taking this problem out of the picture from the beginning. And that's all I have. Questions?
Got one right here.
So for the orthopedics community, what's the general consensus on treatment for hip dysplasia with patients that are advancing? Because say, for example, my son's 2 years old, and if we do say, hey, he needs a hip replacement, they last an average, 15 years, and then they have to be redone again. Or if we break the hip and then relocate it, now he's restricted on progressing his muscles. So have you guys had a meeting on that yet? Or
So there is not really a consensus yet. Addressing hip subluxation and dislocation is sort of the next phase, I would say. Hip replacements are not an option in young children. Just the size that you need in order to do something like that is just not available. And not even until sort of mid-teenage to late teenage years. So I think that the sort of the advance is really going to be on trying to prevent that from happening from the very beginning. My gut feeling is, and this is not, I mean, it's hard to stand at a podium and talk about a gut feeling, but a lot of these problems can be addressed early when they are contractures and muscle imbalance to prevent the problem from happening altogether. In very young children, even young children that are beginning to show signs of subluxation of their hips, the anatomy is still very normal. And it's because the muscles are not strong enough, and some muscles are stronger than others. So it's more of an imbalance in the setting of low tone that causes it to happen. And if you can address those issues early on and maintain the normal anatomy, then bigger surgeries may not be needed in the future. But those are unanswered questions currently. If you asked 10 different pediatric orthopedic surgeons around the country what their opinion is on hips alone in SMA, you would get probably 10 different opinions. And I would say that the majority of people would still be in the mindset that we should not worry about it, and nothing should be done. So we have a long, so of everybody that has talked up here today, orthopedics is probably on the low end of progress in SMA, which is unfortunate, but it's something that I'm hoping that we're going to be able to change.
Contractures seem to be like beasts. I mean, they just come up and they're crazy. There's really no way, in my opinion as a parent, to prevent them. But that being said, my son has a severe contracture going on in his neck. And I know you saw him in the hospital a couple years ago and tried to do a tractioning method, just an old-fashioned type of straightening. Mm-hmm. And that doesn't seem to be helping. And I'm wondering, is there any kind of, like he has a spinal fusion, is there any kind of a fusion type surgery that you would do in the upper neck area. I mean, he's got, the fusion is from T2 all the way down to his pelvic bone. But what would you recommend?
So Botox can be an option for some people. I think do I remember correctly, was that attempted beforehand?
No, it wasn't. And it was about 2 years ago. He was phasing out of the pediatric.
Okay.
And I mean, I think you just, out of the kindness of your heart, saw him in the hospital, but he was like the oldest one there. And, you know,
Yeah.
so you just tried that method, but we didn't go the Botox route.
That can be an option. Even some muscle lengthenings can be helpful for some people. Including the neck and a fusion can be very difficult for the patient. Just taking away any motion to their neck can be really hard for some people. It is something that can be done. Even limited fusions to try to improve the head position. But it would be something that I would recommend maximizing everything else before considering doing a surgery.
Now, what exactly is muscle lengthening? Is that just physical therapy?
Typically the sternocleidomastoid muscle, which is the muscle that's responsible for most muscular torticollis, lengthening of that muscle can improve the head position enough in some people. It's something that's used in much younger children with idiopathic torticollis when they don't improve enough from physical therapy. But I do have some experience in teenage age range with doing that. It would be something that would probably be hard to find people familiar with the technique outside of a children's hospital setting.
I take it you don't see children anymore after the age of, what, 21?
We're limited
Yeah,
by our
yeah.
foundation. So
Is there a place you would recommend going?
we can talk in a little bit. There are, from an orthopedic side of it, it's a very difficult environment. The people that take care of spine problems in the adult world tend to be a bit different than we are. And a lot of them will not see people that have special needs, which is unfortunate. It's still something that I'm trying to kind of feel out within our environment. But there are some options from physiatry, physical medicine, rehabilitation side, and we do have some relationships with some providers that do give pediatric and adult care. So trying that option first and then going from there may be helpful.
Hi, you mentioned that in one of the slides there was an x-ray of a girl, I think, with quite severe kyphosis, and you put the rods in to correct that.
Correct.
What a doctor had said to us once, that kyphosis just makes the patient more vulnerable for scoliosis then to set in. So I was wondering, is that something that you typically recommend, to put some sort of, to intervene to correct the kyphosis, and then you'd intervene again for scoliosis? Or because that's never been suggested to us before, to do something surgically to correct the kyphosis. It's more just what I've understood is eventually there'd be a surgical intervention just for the scoliosis.
So typically it's the surgeries are more for scoliosis. All of the growing for older children, definitive fusions are different. You can control any deformity, but you're also keeping the spine from growing anymore. But the growing options that I mentioned are all distraction based, and they're all applied to the back of the spine. So they can have the tendency to increase kyphosis over the course of time. Most of the kyphosis in children with SMA, though, is very flexible, and it's more of a postural kyphosis. And what the person that you mentioned may have been sort of indicating by saying that is that it is sort of the lack of trunk control and the lack of trunk strength that eventually could lead to scoliosis or progressive spinal deformity. And we see that in younger children as postural kyphosis, so them sort of wanting to lean forward. The one example I showed was sort of an outlier. So her, she also had a very severe scoliosis deformity that was 60 or 70 degrees, so she had the combination of the two. But her kyphosis was also very rigid. So with the technique that I showed, you can control the kyphosis at the same time as you control the scoliosis. But it is sort of a case-to-case basis. And I think that the majority of kids with just a postural kyphosis will do much better with bracing than they will with intervening earlier with a surgical technique.
All right, any more questions? No? All right, thank you, Dr. Ilgenfritz.
Should I advance it?
Appreciate it.